ICD-10 and you see CM, those are the clinical modality codes. Those are the diagnostic codes that we use in the office setting and the hospital setting, whereas the PCS are the more hospital facility oriented codes, the ones that we see used by hospitals in their coding. So PCS and CM are different. We're going to talk about these diagnostic codes as we go forward today. So all I have to do is figure out what I did, there we go, to get my slides to move. All right, whenever we have changes, we always have to look at the guidelines as well. And if you're someone that likes to have the guidelines handy like I do, or not, you can go to the CDC website and print them out. They're about 120 some odd pages. The nice thing is if you print them out from that website, the changes are in bolded text. So you can flip through, and that's exactly what I do to put a lecture like this together. You can just flip through and look at anytime there's text that's bolded that's not a header, and know that that's text that's been either added or revised or changed. And so the guidelines are what show us what we should do in certain circumstances. And if you've never looked at the guidelines, you know, I never looked at the guidelines before I became a consultant. And then as I started to read through the guidelines, I was like, oh, wow, there's actually rules on why we do this stuff. And so don't be afraid to go to the guidelines and see what exactly is going on. Because what we get is very, very valuable information. For example, the level of detail in coding section has added the text to the highest level of specificity in the medical record, documented in the medical record. Now that's important because we know we've always supposed to be coded to the highest number of characters available, but this is reiterating, if it's not in the documentation, don't be, you know, using that higher level code. You cannot interpret physicians' documentation. You really just have to look at what they've documented. So that's a very important addition of a few words that they have there. The general coding guidelines come first, and that's the section that tells us things like what does and mean or with mean, or in this instance, when they talk about laterality, in this instance, they'll say when laterality is not documented, you can code based on documentation from other clinicians. And then saying if there is conflicting information, then you need to ask the provider. Don't just use unspecified because that should be rarely used. Certainly right and left arms, you know, right eye, left eye, you would certainly think that somewhere in that documentation by the clinician, there should be that information. And if there isn't, then we need to have a discussion about anatomy with our providers. Just kidding. All right, as you can see here, they've added a couple of little words, and see right here, this word "the" has been bolded. And so they're trying to make it more read better, if you will. Now remember that when we talk about clinical staff, and that's not just anyone that works for the doctor, and in this instance, they're saying in this context, when they talk about clinicians and who can document in the record, that the word clinician refer to healthcare professionals permitted based on regulatory or accreditation requirements or internal hospital policies. So in other words, they're saying it's not just anyone that documents in the record. Healthcare professionals, clinicians, such as our licensed clinical staff that we see that we usually use when we use the word clinical staff. So they've added that language in there to say who is it that we can use this documentation of. In this section, we know we're talking about documentation and when we can have exceptions. And there are, we know we've had BMI and our pressure, ulcers, and some of the staging. Coma scale's been added, stroke scale's been added, our social determinants of health, now laterality, and blood alcohol level are all part of that clinicians other than the patient's provider that have documentation in the chart that we are allowed to use. And then the addition of this alcohol-related disorder, this F10, as they're adding this into this group of conditions that they're saying we have to have information in the record. It can be documented by other clinicians, but only to a certain point. For example, you can have a BMI that is very high in number, which we all know would correspond to overweight or obesity, but the overweight or obesity is a physician's call. That is their call to make that diagnosis. So although the BMI may be documented by a clinician and we use that documentation to use their BMI or their coma scale or whatever, the additional diagnosis has to be documented by the physician of record, and so that is part of their note. Using under signs and symptoms, it says, it reiterates, if you will, that the introductory guidelines talk about it's a joint effort between the healthcare provider and the coder to achieve complete and accurate documentation. The importance of consistent, complete documentation cannot be overemphasized. The entire record should be reviewed to look at the reasons, but at the end of the day, it's supposed to be a two-way street. It should not be you as the coder trying to figure out what you can and cannot do. It should be, and I know this is a perfect world, and I know I'm a dreamer when I say this, but it should not be, here's what I've done, figure it out. It should be, hey doc, we've had some changes. We need some different documentation from you in order to be able to delineate between the codes that we have. And then the use of Z codes, looking in the guidelines that come based on the chapters, they've added that Z codes can be assigned to further explain reasons that the patients are coming for their services, presenting for their services, and also saying that the Z codes are to provide additional information relevant to the patient encounter, and that's sort of leading into social determinants of health, which we'll hear more about in just a moment. So then after those general guidelines, we go to chapter specific. And chapter specific as in, these are about these series of codes. Now, what's interesting, when I got my new ICD-10 book, is the U codes that are published that we're going to look at for our COVID. The U codes are in the book after the Z codes. So they are way at the back of my book. I had trouble finding them, to be truthful. And yet in the chapter specific guidelines, those U codes, they're pushing them all the way up into this section, because that's most likely, remember we've talked about that these codes and the U codes are meant for codes that they're really pushing out there quickly, that they may well find a better home. Well, the SARS and the COVID-like diagnoses have been in the A and the B codes in the past, so they may end up here. And that's probably why these guidelines are here. So having said all that, we have information regarding history of HIV managed by medication and what we need to do. And just as we see with diabetes, we have an additional code we're going to use talking about long-term drug therapy. And remember the word current that we see in parentheses. The parentheses shows it as a non-essential modifier. That's a word that we don't have to have in the documentation, but if we do have it, it just reiterates that we're in the right place. We have a lot of information about COVID visits and what exactly we should be doing. So the first we see is a follow-up visit after COVID has resolved. So we have patients that come in that have previously had COVID. They don't have any signs or symptoms. They're being seen for a follow-up evaluation and have a negative test. And so we have specific coding guidelines to use that code. And then it reminds us that if we have individuals that have symptoms, we're going to a different guideline. If we have a sequela of a COVID-19 or associated symptoms or conditions that develop following a COVID infection, we're going to assign a code for that condition or symptom and then code this U09.9 post-COVID infection unspecified. Now, that goes against me a little bit, and if it does, you're not alone. Because what we're seeing is they're telling us to code the signs and symptoms. For example, the patient still has they have a loss of taste and smell, and then we use a code basically saying these are post-COVID conditions unspecified, except no, we just told you what they were, but that's the way the code reads. That's what they're telling us to do. And then under the multi-inflammatory system, again, they're telling us assign the codes this is a post-COVID condition. Here's how we use it, just like we did the last slide. And now, if we have this unfortunate circumstance where you've had COVID, you're over the COVID, you have associated symptoms, let's say you still lost your taste and smell, and I think I got ahead of myself, sorry. So sequela post-COVID, associated signs and symptoms that develop, assign that specific symptom and go forward. And again, should not be assigned for manifestations of an active COVID infection. Sorry, there's a lot of text in here. There we go. So now we have someone that has had COVID, they have the post symptoms, and now they get COVID again. So now you have simply, I'll say, a whole lot of codes that you're going to use. And the words will tell you exactly how to do that. I don't want to belabor the point. I'm sorry, I get too excited when I talk about all these COVID codes and what we're supposed to use, because they've finally given us some good tools. Okay, moving on to diabetes. As we just mentioned with the HIV codes and patients that are on long-term therapy, we are saying that we are adding to that list of codes that we use in addition to a code with a patient that has diabetes if they're on long-term insulin use or oral hypoglycemic drugs or injectable non-insulin anti-diabetic drugs. So we have a whole list of things that we now code in addition to the diabetes if the patient is on them. And that's what all of this bolded language is as we go through. If we have medical conditions due to a psychoactive substance abuse, they're not classified as substance abuse disorders. They're giving us specific instructions about how to code for that, in going through exactly what we need to code for. I'll let you read the text. It's a little bit involved. I don't want to waste a ton of time on it. But obviously, if you have questions, please ask. Blood alcohol level, it says code from this category. Evidence of alcohol involvement is determined by blood alcohol level, may be assigned when this information is documented and the provider has documented a condition. The blood alcohol level does not need to be documented by the provider in order for it to be coded. So the blood alcohol level doesn't have to be documented by the provider, but remember from before, it has to be documented by someone. You cannot code that straight off a lab test. And I know a lot of people do that, but if you look at the two guidelines together, there has to be some clinician that's put that information in. Information about using our coma codes, that we can use unspecified coma in conjunction with other medical conditions, and then also some additional information if we have multiple coma scales. History of, the reason for the encounter should be sequenced first. The appropriate personal and/or family history should be coded as an additional diagnosis. So when we have, what are we seeing the patient for? We're going to do screening for a history of. They're telling us we need to use the appropriate screening code or counseling code first, and then the history code goes second according to the guidelines. And remember, these are the guidelines that everybody in healthcare has to follow. So if your insurance company is telling you they want it differently, remind them, ICD-10 guidelines, this section right here says, no, you're doing it wrong. And I don't say that lightly, because I've gotten into some discussions with insurance companies about these are the rules and we have to follow them according to HIPAA. Now we have a new code, Encounter for Immunization Safety Counseling. It's to be used not just for routine counseling. This is for additional counseling, safety counseling. Basically, I think the code, this clarification was created, and we'll hear more about it in a minute, in situations where a parent is coming in, not just, look, tell me about this immunization, this vaccination, but rather it's like, I have questions. For example, like with the COVID-19 vaccine, where they're coming in for more than your just everyday, I have questions about some vaccine that I'm about to get. And then we go on to the SDOH, that's the new buzz acronym we have, the social determinants of health. And it tells us that coding professionals can utilize documentation of social information from social workers, community health workers, case managers, or nurses if their documentation is included in the official medical record. So we have to look at that context when we're looking to pull those SDOH codes in. And again, in the section that talks about diagnostic coding for outpatient, in the level of detail of coding, again, you see where it says we have to have the information in the documentation. All right, so now we finally get to the codes. We have, and these requests come in from all kinds of different places, basically looking to, as you'll see over and over again, improve accuracy, allow them to track better, allow them to monitor something better, see differences between two different types of whatever it is we're talking about. And in this instance, we have under this other rickets, oh boy, and I'll tell you, pronunciation this year is a challenge for me because we got lots of big words. Other ricket, so yeah, whatever. You can read the top. I apologize, I'm not saying it well. But basically, we have this anaplasmosis code. We're in the sort of infection, kind of bug code. Now, this is a tick-borne disease, and it's transmitted by the bite generally of an infected tick. It's usually in a particular section of the country, but what we're seeing is that they're starting to spread, and they want to better track this. And so they're looking to have a specific code for just this. Under malignant neoplasm of the ovary, we have codes that existed for right, left, and unspecified, but they didn't have a code for bilateral. So they said, okay, could we please have a code for bilateral? And then what we have, as we frequently see, is they took a code and they expanded it out by another digit. So previously, we had a malignant neoplasm of ovary code, and now we're going to see the 0.3 is added to the section in order to account for the bilateral ovaries. We're going to see the exact same thing for secondary malignancy of neoplasm of ovaries, where there was not a code for bilateral. And again, in the wonder of ICD-10, again, this code, we have that expansion of a digit, and that digit for bilateral is that last digit of 3. The American Society of Plastic Surgeons is looking for a unique code. It's a unique situation where a patient has a breast implant associated with a cancer. And so what they talk about is it's not your traditional breast cancer of the lymph nodes and the breast tissue that we see, but rather it's a disease in the capsule that surrounds the breast implant. So it's different. It has pathological differences. And so we see this code and also telling us how to code for it, that we're going to pull in that they have, we're going to take the breast implants, remove them, and we're going to get their status in there. Okay, PK deficiency. This, as you see, it says it's a rare congenital anomaly. They're looking, as we see, to have unique codes. And I hate to say it over and over again, but these are why we have new codes, because anybody can apply for a new code where they look to track better. And so when we go into it, we previously had the D55.2 code. We're now going to take that code and expand it to a 5-digit code in order to have 2 codes. One, the anemia due to that PK that we talked about a second ago, and then other disorders of those glycolytic enzymes. Boy, like, as I said, pronunciation is a challenge for me this year. Okay, thrombocytosis and thrombocytopenia. These are conditions where we have an elevated platelet count. We know that these are frequently coded, so this is one that you want to put a star on, because you're going to have to talk to your provider and say, okay, we're going to have some specific codes for some conditions that you're used to kind of coding all together. So we have a new code that's going to come out. So the new subcategory, if you will, is going to be the thrombocytosis with this reactive, secondary, etc. And then we have other thrombocytosis, and then thrombocytosis unspecified. So we need to make sure that they see that. And I would just copy the page right out of your ICD-10 book. And if you don't have an ICD-10 book, I'm sorry for you, because you really, really should have a new book every single year. Okay, hereditary alpha tryptophanemia. As I said, I struggle with some of these words. It's a recently described genetic trait. It can be associated with some things. We had some information from one of the universities. They wanted to track things. There wasn't a specific code. So guess what? Let's give them a specific code, and then instructions that tell us to use an additional code, if applicable, for a couple of different things. The Niemann Pick disease, this NPD, looking for a specific diagnosis for a specific type, and that's exactly what they gave us, and this is a rare. Now here's another biggie to put a star by. We all know that we hate it. We lost our 311 code for depression, and when we came over to ICD-10, the crosswalking code took us to the F32.9 major depressive episode, major depressive disorder, single episode unspecified. And you just went, boy, that just doesn't feel right. Well, guess what? They've determined it to be clinically incorrect. And they're saying, you know what? We need the codes to be better. And so here's what they've done. They've taken the F32 category and changed the title of it to just depressive episode. They've added a new code, the F32A, that says depression unspecified, and also depression NOS and depressive disorder NOS. So your new, if you will, 311 code is F32A. Now they didn't change F32.9, it's still there, but it's no longer what you're going to get if you try to crosswalk your 311 or if you try to look up a code for just an unspecified depression. And for that, I'm excited. Of course, I get excited about ICD-10 stuff anyhow, so. All right, we have a number of specific genes which have been found to be related to intellectual disability. One of the more common ones is this SYNGAP1. And so, again, looking at tracking and looking at being able to do research, et cetera, they have a new subcategory that was created, and then we go into a new code with some code also indications. Acute flaccid myelitis, as you see, is a rare but serious neurological condition. They are doing research all the time, and they're trying to better allow for a standardization of the comparisons that they can make. So what they have is a new code, and then instructions, as I said, and we'll see a lot of that this year with code alsos. We have a new, or not a new, but a type of headache that is very unique. It has some very specific indications and information that we're going to look at. And so when they asked for a new code, we are going to have this, it's a cervicogenic headache. Now, it can be associated with cervical spine condition, and so we're going to code that if we have that information, but it has a very specific pain pattern, as you can see. This chimeric antigen receptor T cell therapy, it's been a welcome treatment, they say, of looking at relapse or refractory leukemia and certain very specific types, but there have been some significant complications that have been observed, and so what we have is two of the most prevalent complications. And so they're looking and saying, you know what, can we get some better information? Can we get some better codes, if you will? And so they requested some codes. They talked about signs and symptoms. Again, just kind of going through the information. This is a perfect example of where I've given you all the information that I could find on going into these new codes so that you can have it as a background for the logic. Because at the end of the day, what do we have? We have a new subcategory, and then that category has been expanded out so that we have this set of codes for this immune effector cell-associated neurotoxicity syndrome. It is differentiated by grades, and then the last two codes have other and then unspecified. Looking at our current ICD-10 code set, we don't have a specific code that corresponds to a non-traumatic myocardial injury. And apparently this is a high severity of illness for patients that have this. And so making sure that they can as they use the words align appropriate diagnostic and treatment strategies while avoiding inappropriate approaches because of misclassifications and qualifications within the codes. They're like, okay, you know what? Let's look at having some unique codes. Now, I put this little part in here because this just looks all kinds of sideways to me, because it's found in the I-25 section. It's, you know, found out at the end, and as they start to add these A codes, I want to see the logic on how we suddenly have all these A codes kind of squeezing in codes here and there. But this is a new code for this non-ischemic myocardial injury, non-traumatic. Remember, essential modifier, don't have to have those words. And then we have acute, chronic, and unspecified. It tells us to code first an underlying condition if known, pardon me, and they talk about those specific kinds of conditions within the code set. An esophageal polyp, if we look at this, we see that there is, again, no unique code for this esophageal polyp or esophagogastric junction polyp. And they want to be able to capture polyps if they're not documented as non-adenomatous. So, and I put one picture in. I hope we're not too close to lunch that people have a problem with it, but it's just to show, and I showed this just to show, I think it's very unique how, as we go down into your esophagus, how that lining is so much like the inside of your mouth. It's very, very smooth. And so this is just a picture that I pulled off the internet for this type of esophageal polyp, and looking at the new codes that we have with this new subcategory and its expansion. So we're in this section. We have new codes being requested in order to help them understand, and they're looking for identification of this gastric intestinal metaplasia. If you've ever heard of Barrett's esophagus, it has apparently similar precursor lesions for esophageal cancer. And so they're looking at the location of this as a significant predictor. And so here are our codes for that. Noticing there are significant breakdown of the codes with and without dysplasia, with the fundus, with the cardia. So there's lots of specificity in these codes. All right. Along with multiple vital functions, we know the skin acts as a barrier to protect the body against any kind of problems, mechanical trauma, you know, too much fluid, other pathogens. And so an overexposure of the skin to moisture can compromise the skin's integrity in that epithelial layer, that normally acts as a barrier. We know that once that skin is damaged, it's more permeable and is more susceptible to irritant penetration, leading to inflammation and maybe even a dermatitis. So we are looking at this moisture-associated skin damage, which delineates a whole spectrum of injury characterized by this inflammation and erosion. And so as we have an aging population and we have more of this moisture-associated skin damage, they're looking to have more codes to better identify it, and as it says, to improve data collection, facilitate research. So here's our new subcategory, and then our codes. So we have due to friction or contact with body fluids, due to saliva, and I'm going to let you read the rest because it is somewhat close to lunch, I think. And there's some other codes. The hematopoietic stem cell transplant associated thrombotic microangiography, big word. It's a serious multi-system life-threatening complication of some stem cell transplantation. There are organizations saying it would be much easier for them to characterize and to understand how often this really happens if they could have their own set of codes. And so here we have codes for this thrombotic microangiopathy. Whew. New subcategory, and then 2 codes underneath it. Sjogren's syndrome, when we look at the way the words are laid out in this M35.0 code, it just wasn't clear, if you will. And so what they've done simply is revised from this Sicca syndrome with Sjogren in brackets to say Sjogren's syndrome, and then underneath list the Sicca syndrome as an additional verbiage to be coded to it. So what they've done for these whole sections is they've taken this language that sometimes just says Sicca syndrome, changed it to Sjogren so that all of these codes have that same change. So it was really just more of a technical change than anything else. But as you can see, there are a significant number of codes we're talking about. Okay, non-radiologic axial spondyloarthritis is a potentially severe chronic inflammatory arthritis. It primarily affects the joints within the trunk area. It causes unyielding, non-mechanical back pain and has a progressive diminishing of spinal mobility and physical function. And so as they look at what's happening to these patients, they're looking to better identify who they are and have, as we always say, a code more unique for them. And so here's our new subcategory, non-radiographic axial spondyloarthritis, and then the whole set of new codes. Notice the difference in the codes is where is it cervical, cervical, thoracic, so, and on down. Something to put a star on, low back pain. So there is a company called Relevant Med Systems is proposing the creation of new codes for describing low back pain. Whenever I see a company doing that, I think there's a reason, you know, whether it's equipment or medication indicated. So what they're looking to is make these coding changes to better identify and track this very specific condition. And so our low back pain code, and I know many of you are used to this, but this low back pain code is that M54.5 is no longer going to be a valid code. You're going to have to go to a 5-digit code, if you will, in order to get your low back pain that's either unspecified, or if you have additional information, use the other low back pain. And remember, whenever you have other and you're using that as your diagnosis, you need to have other information in your documentation that's saying that it supports the use of other. And then of course there's the code, the reason for the request, which is the vertebrogenic chronic low back pain. I'm sorry, low back pain. I used the word chronic, that's incorrect. So they're just looking to be able to identify this better. And so, you know, we've got this biomarker that improves the diagnostic accuracy. And my assumption is the company that applied for this is probably the producer of the biomarker. And that's what happens. They like to show the delineation for research, for reasons of identifying product use, whether it's mechanical products or whether it's medication products. Okay, we've moved into the section and I just go alphabetical, if you will, through the system. We know that a mother can pass group B streptococcus to her baby during delivery, and it affects about 1 in every 2,000 babies in the United States. Now, not every baby who is born to a mother who tests positive for this becomes ill. It's uncommon, and the outcome to a newborn, unfortunately, can be quite severe either way. As such, physicians include testing as part of their prenatal care. Newborns that are at increased risk for this if their mother tests positive for the bacteria during pregnancy. And so the American Academy of Pediatrics is requesting this new code, as you see, allow for adequately tracking and monitoring. So here is our code, newborn affected by maternal group B streptococcus colonization or contact with positive maternal group B strep. Again, the words in parentheses are non-essential. We have 34 core conditions that are part of this recommended uniform screening panel with 26 target conditions. We have a listing of disorders that are recommended by the Secretary of the HHS department for states to screen as part of their universal newborn screening. So they're chosen based on evidence that supports the potential benefit of screening, and most states do the majority of the ones recommended. And then we do have new conditions that are always being adopted. Some states adopt them, other states don't. But there's 4 main categories of conditions that are screened for by every state, and those are the 4. So under the other conditions category, we have, as you can see, screening for congenital heart disease, which is performed on all newborns. And currently, some of this is mandated by law in the 2nd state. This is mandated by law in more than half the states. Boy, my mouth just got going way too fast. And so there's reporting guidelines for these codes, when to report them, when not to report them. And as you can see, additional information even before we get to the code. And so now we're going to add some verbiage before the codes, and then we have those new codes, the P09 codes. Cough, put an asterisk on this. Something else that you're going to have to make a major change with if you're in a primary care type arena, but also if you use that diagnosis of cough. We know that what goes on with a cough, that's on the first slide. We know that there are guidelines that you can find in several places for what constitute a chronic cough or what constituted a refractory cough. But something to remember at the end of the day, what's in the documentation? If your provider comes to you and say, well, what should I write? It's like, no, wrong direction here. You're the clinician, you do the research, you decide if you're comfortable calling this a chronic cough versus an acute cough. There are guidelines out there for them to follow. They need to follow them because they're clinical guidelines. And there are different clinical guidelines, so they have to decide, is a chronic cough at 6 weeks or 8 weeks or 7, or could it be 10? It has to be their decision, because our job as coders is to simply code what is written in the record, and they're the ones that have to do the research to come up with that. So in this new cough section, we have some excludes 1. In other words, if you're looking for smoker's cough, you're in the wrong place, or cough with hemorrhage. And then we have new codes for this acute, subacute, chronic, etc. For all those coughs. Nocturnal polyuria, so waking up at night to go to the bathroom and having too much urine. And so we have this problem that people have. We don't have any code to fully describe this, and so we're going to have this, take this new subcategory, and underneath it have 2 brand new codes. The American Psychiatric Association, we don't have a unique code when someone does a non-suicidal self-harm behavior. So it's important to establish codes for these self-harming behaviors so that they can show the difference between someone making a suicide attempt at self-harm and a non-suicidal attempt at self-harm. So this new acronym, the NSSI, involves the deliberate and self-inflicted destruction of body tissue, resulting in immediate damage without a suicide intent. And so these are people that are deliberately harming their own body. They use the phrases by cutting or burning or banging or punching objects or punching themselves. It's not meant as a suicide attempt. It's just a harmful way to cope with their emotional pain. And so they want to be able to track this better. So here's our code for non-suicidal self-harm with instructions telling us, code also the injury if you know what the injury is. And then we have a personal history code for this. All right, we have pediatric feeding disorder. It can be described as impaired oral intake. That is not age appropriate. Boy, that sounds like a lot of words. But at the end of the day, it may include things like not being able to feed effectively, So we have, a cascading effect that can affect the child's, physical, social, emotional, cognitive function. It can increase caregiver stress. And so basically looking for codes in order to delineate this out. So we have 4 important domains that underlie this pediatric feeding disorder. We have some comments about how long the symptoms will last. And then there's our code for feeding difficulties. Abnormal findings of blood amino acid level. We don't have, currently, we have homocystinemia and homocystinuria are coded to the same code. And so let's try to get codes, that more adequately reflect what exactly it is that we're seeing in patients. And so here's our code that has abnormal findings of the blood amino acid level, where it talks about the homocystinemia with an excludes 1 note for specific findings that indicate disorders of amino acid metabolism. Traumatic brain compression and herniation is one of the most common causes of brain or TBI injuries that we see. We have compression of the brain tissue, and then we have herniation that occurs in the areas inside the skull. These are things that require a 7th digit to the category. There are only 3 7th digits that are appropriate. So there's our new subcategory and code, and then telling us to code first the underlying traumatic brain injury. And there are some additional codes about that brain compression with and without herniation. Synthetic cannabinoids are a real problem. We have these medications that have contributed to illnesses, injury, and death. They are off the market, and they are not mainstream market. They are not tested. There's no uniformity to them. And so there's all kinds of issues that they are trying to track down. They're not well studied. They're not well understood. When we looked at ICD-10 before this year, there was no distinction between cannabis and synthetics, and they're very different in their chemical structure, how the law looks at them, in many other ways. So there was a proposal to say, could we please have a code for this synthetic cannabinoid poisoning? And so this T40 category has 7th digits. There's only 3, just like with that last set, that we're going to use the A, D, and the S. Here's our new codes, and as we frequently see in our poisoning section, we have that accidental, intentional self-harm, assault, etc. Categorization to try to get what was the intent. We see here with the poisoning by synthetic cannabinoids, the same accidental, intentional self-harm, etc. And then they're taking this previous section and just deleting it. I don't know if you've ever seen one of these. We used to see them sometimes on the beach, and they would look dead, but they would always tell us to stay away from them because, as you can see, they have very long tentacles, and those tentacles, even if the animal itself is dead, those tentacles still have stinging medication in them that will hurt you. And so that's just a story because the change here is the way they spelled the word Portuguese. And they changed the way they spelled Portuguese. That is the change in the code, is the correct, what they're saying is the correct spelling of Portuguese. Okay, we have the Alliance of Dedicated Cancer Centers is requesting a code to capture complications of immune effector cellular therapy. It'll enable them, as we've heard over and over again, to report and track. There's no codes that are specific to this right now. So here's another T code. Because it's a T code, it has a required 7th digit. And as with the other new codes we've seen this year, there's only 3, the A, D, and the S. We have instructions with excludes 2 notes and also use additional instructions with the code. Okay, post-COVID infection. The coronavirus SARS-CoV-2. We know, and I kind of touched on a lot of this at the very beginning because I always get ahead of myself. And as I said, I get excited when I look at the codes that we have for our SARS, for our COVID-19 virus, because we're just so hungry for information. So we know we had the new category, the U09, which was the post-COVID condition. We talked about that already. And then we also mentioned about this new code, this post-COVID-19 condition, unspecified, and how we're supposed to use it. So we've kind of already beat that horse to death. But that's where the new code sits. And so that's why we're talking about it there. The information given about these this new code that's coming out included information saying that they have surveillance technologies that have facilitated national and international awareness of an upward trend in the rate of injuries to law enforcement officials, bystanders, and suspects regarding resulting from illegal intervention. However, the ICD-10 system does not appropriately describe modern-day mechanisms of injury to a suspect, bystander, or law enforcement official. Lack of concise data is a barrier to fully understanding the origin and downstream effects of injury from a legal intervention. So the current category Y35, legal intervention, does not completely capture mechanisms of injury in a modern-day encounter. As a result, we have other codes. They fail to provide the necessary information to specifically track stuff. And so they're saying, okay, these codes for legal intervention are just not being handled right. So they're asking for new codes to differentiate the cause of injury involving if someone is, quote, manhandled or, quote, body force is used. So there's our 7th digits. The Y35 section requires that. A, D, and S are the 7th digits that we're looking at. And the code reads legal intervention involving other specified needs, unspecified person injured. Social determinants of health. We know we've started to see these. There's a project that was created for coming up with these social determinants of health called the Gravity Project. And they are looking to help identify and are charged with developing these data elements and data standards for the social determinants of health. So look for more under this listing of Gravity Project. So under our social determinants of health, we have a new code, less than a high school diploma. Codes for problems related to physical environment, inadequate drinking and water supply. A new subcategory for the homeless. And then delineating, is this a homeless unspecified? Is it someone that's sheltered but homeless, or unsheltered homeless? I mean, they're doing a really amazing job at these SDOH codes. We also have codes for food insecurity, lack of food, housing instability, some timelines for that, other problems related to housing and economic circumstances. So we're going to have to get used to these SDOH codes, social determinants of health codes. They're going to be used more and more, and they're informational, if you will, again, based on documentation. But I truly believe they're here to stay. And then remember, I mentioned immunization counseling. So we have parents and caregivers that are seeking counseling services. They don't have signs or symptoms. They're unrelated to medical care. And so although we have a number of codes for a variety of different counseling services, there's no codes for counseling services related to an immunization. A unique code was therefore requested to identify encounters where the parent or patient is present, specifically for vaccine counseling. Now, in the application for the code, they talk about typically parents want an alternative vaccine. Alternative vaccine is scheduled, or they want to spend time with the provider to ask them questions about vaccine safety. It's important to be able to show that counseling is being done particularly when a patient does not have an update immunization record. So they are looking, again, to better serve patients. And so here's our encounter for immunization safety counseling, telling us to code also the encounter for the immunization. And that would be as appropriate. And then we have this alpha-gal syndrome, which has been associated with allergic reactions to red meat and other products made from mammals. In the United States, the condition most often occurs from the Lone Star or deer tick bites. And so the bite transmits a sugar molecule, and in some people, this triggers an immune system reaction that later produces mild to severe allergic reactions, and it's to the actual red meat. We have signs and symptoms of alpha-gal syndrome, may include hives, itching, eczema, and there's a wealth of them, if you will. So looking to get some additional codes out of the way, there's our allergy to mammalian meats. And at this time doesn't matter what the animal was. And then looks like we're right coming up on the end. We have the Alliance of Dedicated Cancer Centers. Let's back up a little bit. In 2017, the FDA approved the first CAR-T products for use in the treatment of certain blood cancers. There were patients that were seeking clinicians to assess their status after therapy, including treatment response and to address late onset complications. The typical complications of the CAR-T therapy included cytokine release syndrome and/or neurotoxicity, which usually occurred in the first few weeks after receiving the cell infusion. Sometimes, however, the complications could occur post-discharge and could be the reason for additional medical encounters. There wasn't any ICD-10 code to capture the status of a patient after receiving CAR-T therapy, and so this new code was requested to accurately track patient outcomes, the reason for additional tests, and or treatment and additional resources that might occur as a result of the patient's status as a CAR-T recipient. And there is the new subcategory, which then gets expanded out, and the codes that you need to use.